to the 3 o'clock Tuesday afternoon talk with Dr. James Park from the HOAG Epilepsy Center, which is a level 4 center for epilepsy. Dr. Park is going to go over understanding your EEG, and he assures me that he has read more EEGs than romance novels.
Way more. All right, like Sherry was saying, I'm here representing the local centers. We're at HOAG in Newport Beach in Irvine, California. I've been here for about 5 years now, kind of helping to grow the program, and we're a level 4 center where we do kind of all the different types of evaluations and surgeries and everything for epilepsy. So I'm just going to talk to you briefly about EEGs and just kind of what to expect and what we're looking for and things like that. So what exactly is an EEG, or an electroencephalogram? So it's a test that that measures the electrical activity in the brain, and typically that's done with kind of these gold electrodes that you put on the scalp, and you see the person in the middle where typically it's pasted on with some tape on top, and the technicians measure out how far kind of on each person's head it goes, and basically it's just monitoring while it's on. They may even do caps like this just for quicker kind of application and things, but that's typically what an EEG is. There are different types though, so what you might expect kind of getting it done for the first time is probably a routine or extended EEG. Typically runs for about 20 minutes to an hour. Put it on, take it off that same kind of morning or afternoon. But they do have ambulatory EEGs, which is something that your doctor may want to do just to get more information. So that's worn at home for anywhere from 24 to 72 hours. And then really the gold standard for kind of sometimes diagnosing things is with a continuous video EEG. That's done usually in the hospital or in an epilepsy monitoring unit. And that's where the EEG and the video are kind of monitored and recorded for anywhere up to a week, sometimes even longer depending on the case. And then lastly, you have intracranial monitoring, which is actually electrodes put either into or on top of the brain to study the seizures a little bit more closer to the actual source and try to localize it a little bit better. So what does an EEG actually look like? You'll see it on here. It just looks like squiggly lines, right? So every kind of normal case will look a certain way when you're awake, when you're asleep, when you're drowsy. So there are different things that we look for. And then you're also comparing the two different sides a lot of times. So as you see here, odd numbers are left side, even numbers are right. They have different letters associated with it, so that's kind of pointing to different areas of the brain that the electrodes are covering. And kind of scrolling through these squiggly lines is basically what we do. So what does an EEG tell us? So it's not like looking at a single neuron as in the first picture, or even a group of neurons. It's really a broad overview, right? So what I like to say is that an electrode that's on the outside of the scalp here is kind of seeing all the electrical activity from all the neurons that are kind of combining and coming to that electrode. So if you see a seizure here, let's say for instance, it doesn't always mean that's the exact spot. It could be spreading from other areas. It could be coming from deeper focuses and things like that. So again, an EEG that's on the outside of the scalp is kind of giving you a general overview and a general region, in a sense, where we think seizures are coming from. So what exactly are we looking for on the EEG? So like I said, comparing the different regions, the two different sides. So for instance, there may be focal slowing. So as you see in the first picture here, I don't know if you see my arrows. No. On the bottom of the page, you'll see how a little bit slower here than in here, right? So that suggests that region of the brain is a little bit, there's some dysfunction there. So that can sometimes be a hint for where kind of things could be going on. The second picture is more of a generalized slowing, so sometimes when patients are in the hospital confused or medications and things like that, you may see more kind of generalized slowing as well. And then epileptiform discharges is kind of an even further step in terms of trying to figure out where seizures are coming from. And so what these are again, hints of excitability in the brain. So if you see either sharp waves or spikes, or these are just all descriptions of what they look like, right? Spike and wave, polyspikes. If you see any of these things in one little part, or even in kind of generalized in kind of genetic cases sometimes, that kind of gives you some information about where you think seizures are coming from. So what does a seizure actually look like? This is actually one of my patients, just to show you kind of what a focal seizure is like. But you can see the first half of the page, that's actually pretty normal. He's awake. Those big deflections down are actually eye blinks. And then what happens in the second half of the page is you see some rhythmic activity developing, right? Like right here. So that's the seizure that's developing in kind of the right temporal region for this patient. And as you can see, it's kind of building up and it's spreading. So that's typically what you will see in a seizure. Start with a focal seizure. You'll see it start in one spot. You'll see that electrical activity build up and then spread to other areas of the brain. And then when that happens, in his case, he's not aware, he loses awareness, he's doing things like lip smacking and things like that.
So that's the dark part, that is the lip smacking?
This is just like muscle activity. So sometimes, yeah, people will lip smack and you'll see that muscle activity. Sometimes people clench their jaws or whatever. So you'll see, and that's where there are sometimes some limitations. If there's a lot of muscle activity, it could hide what the EEG is showing. But yeah, that can happen sometimes too. So yeah, just building up and spreading is kind of what I'm showing here. And this is more the muscle activity where people may kind of stiffen and shake. And that does obscure kind of what the underlying EEG is showing. So what about like generalized seizures? So this is a very typical example of, let's say, like Absence seizure. So someone who has genetic type of epilepsy, it starts in the whole brain all at once, and you see these kind of very characteristic spike wave discharges, typically at a certain amount per second. And during this time, a patient will be kind of just staring off unresponsive for a few seconds. Some people can actually have slightly different, it's not always just rhythmic activity developing, but in this case, for instance, this is a tonic seizure. What you'll have is like normal activity and then it just suddenly flattens out for a little bit, as you see kind of in that first half of the page. And during that time, patients kind of, everything stiffens and then relaxes again, for instance. So there's all these different patterns that you can see with seizures, and really each patient can be very different. So these are just very classic examples of kind of different types of seizures, but really, sometimes all you can see is very subtle rhythmic activity that builds up and spreads. You may not see these spikes and things like that. So really, every patient is going to be a little bit different, and so you like to capture a few kind of different things during monitoring if you can. So as I said, kind of what do all of these things tell us? Main thing is trying to figure out what type of epilepsy you have and where seizures may be coming from. So again, there's focal and generalized epilepsies. So focal means, again, starting in one little spot, spreading to other parts of the brain, and generalized epilepsy means more kind of starting in a deeper focus and kind of going to the whole brain all at once. And those, again, are more of what we consider genetic epilepsies. So typically starting in childhood, maybe late teenage years and things. And why this is important is because our treatment plan changes. So different medications may be used for the two different types. So we have what are called narrow and broad spectrum anti-seizure medications. So narrow spectrum medications may be useful in focal epilepsies, but sometimes, again, classically thought to maybe worse in generalized epilepsies. Versus broad spectrum will kind of treat kind of all different types of seizures and things. So that's where knowing the diagnosis can help kind of what we're doing. And then surgical options are going to be very different. So focal epilepsies, again, you'll have different resections and devices and all these things available, versus generalized epilepsies will have different treatment options. So just to go over like some other things that we see. So those are like the abnormal things that we typically look for, but there are a whole host of kind of what we call normal variants that can sometimes be mistaken for abnormalities. Just an example is what we call wicket spikes or rhythms. What you'll see here in the first picture, where the arrow is, right? See a little bit of rhythmic kind of sharp activity, right? So some people might look at that and say, oh, that's abnormal. That's where like it looks irritable there. But that's actually normal. We can see that in kind of drowsiness in adults and things. So again, a lot of times that can be mistaken for an epileptiform abnormality. The second picture here is kind of giving you kind of how different they look. So a wicket spike, as you'll see on the bottom, kind of they're even on both sides and just it's a spike, and it doesn't disrupt the background at all. Versus an epileptiform discharge or spike, it's kind of sharp and then has this long kind of slow wave after, meaning it's disrupting the background a bit. That's how sometimes we kind of differentiate the two. But again, it can be difficult sometimes, and people can have both, right? So you can have wicket spikes and epileptiform discharges on the same person. So catching more of these can help you differentiate sometimes between the two as well. But you can see how it might be easily mistaken as something abnormal. Kind of going along with that is what we call rhythmic mid-temporal theta drowsiness, or RMTD. Again, you see this rhythmic activity kind of on the top of the page, the top 4 lines. And again, that can be mistaken as, oh, it looks rhythmic, maybe a seizure could develop from there, but this is something that we can normally see in drowsiness. It can happen just on one side, can happen on both sides. That really kind of doesn't necessarily make it abnormal. Again, something that if you have experience with it and know to look for it again, then versus someone who hasn't seen this before might mistake it. Even harder to see, benign small sharp spikes, or BETs as we used to call it, benign epileptiform transients of sleep. I don't know if you can see where the arrows are pointing, but there's these tiny little spikes there. And again, someone may see that and say, oh, looks like there's different areas that I've seen reports where it's like multifocal spikes and things like that. But really, again, this is normal in sleep in some patients. So, and those are just a few of the different normal variants that we may encounter. And so the main thing with EEG interpretation in terms of issues is again, depends on who's reading it. So kind of what's the doctor's experience with it, right? Have they seen these things before? Do they know that they're normal variants versus abnormal, for instance? And then also depends on what's captured. So, we could do a 72-hour EEG, but if we just happen to, by chance, not caught what we wanted at that time, and it's normal, it doesn't necessarily rule out epilepsy. I've seen patients who have normal-looking EEGs up until the moment they have a seizure. So, again, a normal EEG doesn't 100% rule anything out. The other part of this, I think, as we move into the future, that is really going to change is chronic monitoring. So everything we've talked about in terms of EEG has been like, you put it on the outside of the head, you monitor for a few days, and you take it off, right? But what if we could monitor the brain constantly, right? So we're starting to see that now with patients who have a device in their head, what's called a responsive neurostimulator, or RNS. These are patients who have refractory seizures, right? So seizures that were not being controlled by medications, and we put a device in to help treat the seizures. But the other aspect of that where it's helpful is actually we're monitoring the seizures constantly and capturing all this data for when they're having seizures, what they look like and things. And so for an example, a device like this where we have different leads in different parts of the brain, you're seeing kind of again seizures being captured and data collected. And what they've been doing with that actually is then using it to kind of see if there are any trends. So this chronic monitoring is actually allowing us as doctors and researchers to really see, is there any kind of anything that we can glean from all this data, right? So they're starting to see certain people have certain rhythms. So I think it's like the bottom one of the panels where do they have like a 10-day rhythm to their seizures or a 28-day rhythm or whatever it may be. And the joke was when this data came out is like, oh, when patients used to say, yeah, like I always have more seizures when it's a full moon out, we kind of go, oh yeah, whatever, right? It actually may be true because maybe they're on some kind of whatever 28-day cycle or whatever, and it just happens to be during a full moon, yeah, they have more seizures or a higher likelihood for seizures. We're also seeing then with women, for instance, menstrual cycles, right? Do their seizures correlate with that? Or medication changes. Sometimes with this chronic monitoring, you actually see when you start a medication that the seizures actually decrease or stop. Or if you make a change in the device, you see the seizures decrease or stop. So I think this is going to also change kind of how we do things and approach things in the future, especially as, there's people like Elon Musk talking about implanting things in people's heads and things like that, right? So, but this is just an example of how, again, we're using this chronic monitoring, which in the past we never had before. So. Any questions? Yes?
My son has focal aware seizures,
Mm-hmm.
and this past spring he was having more than normal, but they were like 10 seconds long, like every hour. So the doctor ordered an EEG, and the EEG did not pick them up.
Mm-hmm.
Was it because they were so brief? Were they PNES
Yeah.
episodes, or any ideas?
It's harder to say because so with focal aware seizures, where again patients don't lose awareness with it, it's just the feeling. It means that seizure can be very small and limited to a certain area. So again, if you have an electrode that's on the outside of the head, you're only going to pick up stuff that again builds up enough to actually see it here. So, and your skull is a big thick piece of bone, so it actually acts as a filter. It's going to filter out some of those things. So with focal aware seizures, the one caveat is that we always say is that even if you don't see anything on EEG, it doesn't rule it out because, again, you often may not see a correlate on the scalp. But if you happen to put an electrode in, let's say if we were monitoring it to prep for surgery and things like that, you may actually see that there are EEG changes with that because then you're taking away the skull, and then also you're putting the electrode into or close to where you think the seizures are occurring. So that's unfortunately the only way you can definitively say, but a lot of it is also just going to be the clinical history and things like that, like how stereotyped are they and those kinds of things. So and sometimes we don't have a clear-cut answer and we just treat it and see what happens, for instance. And that may be a more helpful supporting evidence too, that if you treat it and they go away, right, that probably says that they are seizures, right? So, and PNES I would say is a separate kind of thing where, yeah, monitoring and things can help figure out, but that's more, it would be more helpful in bigger seizures and ones where patients are losing awareness and things. Do you see any changes in the EEG at the time? Yeah.
Is that the same as the absence seizure?
No, so and this is where it's just purely terminology, right? So I know as patients and things, they use those terms interchangeably, but if you're being like very kind of a stickler for the terminology, absence is more the genetic type of epilepsies, like the EEG I showed, where it's kind of all the spike waves at once, that short burst. That is more of what we call an absence seizure. So just brief staring off, unresponsive, and then kind of coming back to. People can have staring off and unresponsiveness with focal seizures too, what we call focal impaired awareness seizures. So it can start in one spot and spread, and if it's involving enough of the brain, then people actually do lose awareness too, and stare off and things. So it can look very similar. So that's where a lot of times it's just getting the information, history from patients and family. That's often helpful for us to try and figure out what type of epilepsy you have. Not always EEG necessarily, because again, EEGs can sometimes look normal when you get it. So a lot of it's going to be the history.
She can't tell me, but she sometimes stare off, or she'll say her eyes twitching. So is it twitching and anxiety, or it could be a seizure?
It's hard to say, yeah. Sometimes again, catching it on an EEG and things may be helpful in that case. With the eye twitching and stuff, you have to, yeah, it could be absence, for instance. Any other questions? Yes.
So he has a specific focal aware seizures with these symptoms, but then he also has something the doctors are calling auras with a different set of symptoms. He's still awake, but they happen less frequently. Would you suspect an EEG would pick that up, or not, or it may not pick it up, but it'd still be an aura sleep seizure?
So auras are technically focal aware seizures too. So focal aware seizure just means whether or not you lose awareness, right? And focal just means it's starting in one spot. So could you have different symptoms because you have two different spots that cause seizures? Yes. So and different symptoms, right? So a focal motor seizure, which is stiffening and shaking on one side without losing awareness, is still a focal aware seizure, just like an aura where you have like deja vu or whatever it may be. It's still a focal aware seizures too. It's just the symptom is different depending on where it started.
You would suspect that EEG would pick those up?
You may not. Yeah, I would say a majority of the time you're not going to see much on the EEG.
How would you catch that? Would you have to do a grid, or how would you plan for an SEG to find the location?
Depends on the symptoms and what your hypothesis is. So that's like the epileptologist will have to kind of decide that. So again, what symptom you have can often dictate where we're going to be looking, right? So if you're having visual symptoms, for instance, you're going to be looking kind of more towards the back of the brain. If you're having anxiety, deja vu, or kind of more emotional symptoms, you're looking more mesiotemporal. If you're having motor symptoms, again, you're looking more in the motor kind of areas and things like that. So it really depends on that. And with intracranial monitoring, it's you can't go spearing the entire brain. So you're basically saying, okay, what's my hypothesis? What do I think? Where do I think this is likely coming from? And putting electrodes in as many places as you can without obviously doing harm and things. So, and you may not catch it. It's just unfortunately sometimes sampling error. But again, that's why it's important to have a hypothesis about where you want to go and using other modalities to try and figure out where you think seizures are coming from.
On the at-home monitoring, we can catch the absence seizure, or?
On EEG monitoring? Yeah. So if you do like a longer EEG, let's say ambulatory one or even in the hospital, and she has an episode of kind of staring, blinking eyes and things like that, you should be able to see that on an EEG. Unlike focal aware seizures, the generalized epilepsy seizures you should see.
But if she has anxiety, does that show up on an EEG?
No, if it's anxiety, if it's just anxiety or stress, that may not show anything on the EEG, which then actually may help. Again, that kind of study may help you to decide what to do. Because if it is a seizure, then you're treating it as such, right? But if it's not, then maybe it's treating something, anxiety or stress, things like that. Yeah. Any other questions? All right. Well, thank you very much. I'll get you out early, and then I'll be up here if anyone wants to come talk specifically about anything.